Okay, so we're back to talk about postpartum depression and psychiatric disorders. And these are important and they're kind of close to my heart because a lot of women suffer unnecessarily with mental health disorders after they deliver. There's a hormonal basis for a lot of it. Um, and it is a developmental crisis to have a baby, especially if it's your first. And so we want to talk about this and talk about ways to help women and ways to help them understand that they don't need to be ashamed um, or fear some kind of punishment. So, postpartum depression, this statistic really shocked me. I had always heard 10%, but up to 20. That's 1 in 5 women after giving birth. Think about how many girls are in your class who someday might have babies. 20% is high. It's a lot of people that this affects. And the reason that a lot of them suffer unnecessarily is that they have the stigma that I had a baby. I'm supposed to be overjoyed. Look at all those pictures of women smiling at their babies and looking perfect, and they're handling everything beautifully. And it prevents them from getting help. They think they're bad mothers if they admit that they're not happy. It can interfere with bonding. It can interfere with infant development. So mom's not the only one who suffers. You think about it, she doesn't interact with her baby as much, even if she wants to. She's not smiling. She's not cooing. She's not making those high-pitched noises, or that speaking in that motherese kind of language that women have with their kids. She's not singing. She's just kind of surviving, and so it can impact infant development. Risk factors: any history of a mood disorder at any time in a woman's life, particularly if it happens when she's pregnant, whether it's depression. Sometimes we say anxiety disorder and OCD come back in postpartum period. Um, but that it impacts your risk for postpartum depression because you already have sort of a biochemical maybe imbalance of serotonin and dopamine. And so the hormonal shift could tip you over into a mood disorder. Stressful life events. A woman who is already trying to cope with having a baby, who has other stressors in her life, particularly major stressors, loss of a loved one, moving, loss of, any kind of loss, any kind of major stressful life event, divorce, anything like that, can impact her risk for postpartum depression because she's exhausting her coping skills. Unplanned pregnancy or ambivalence, because sometimes they get those baby blues and they think, well, I didn't plan this. Maybe I don't love my baby enough. Um, and sometimes those negative cognitive distortions can impact the risk factors for postpartum depression. Lack of social support is a big one. Not only does this mom not get social support, but probably she's not getting a lot of help with the house or with self-care, with sleep. And so that can impact her risk. Complications during pregnancy or delivery when things don't go the way you planned them leads to anxiety and maybe that sort of negative image of her experience. And then body image issues that arose during pregnancy, body image issues during postpartum. The body postpartum has been through a lot and it looks different. Like pregnancy is something that we sort of almost celebrate now with the cute maternity clothes and things like that. And everybody shows off their bump on Instagram. Well, nobody shows off their postpartum belly on Instagram. Let's face it, the skin that was taut over that belly is now sagging. The stretch marks are still there, and you see them a little bit more prominently. Maybe mom's breasts are like engorged, and there's a lot of things that happen postpartum that can lead to body image issues. So signs and symptoms of postpartum depression. And you can contrast this with the baby blues. Persistent sadness. This isn't like the emotional overreaction that comes and goes, and it's sort of interspersed with happier feelings. This is persistent sadness or lack of joy, lack of interest in things she used to enjoy, can't laugh, can't smile, just feels very down. Disturbances in eating or sleeping. Some women will eat more, some women will eat less, some women will sleep not at all. They'll get insomnia. Other women will sleep anytime they don't actually have to be awake. And it's sort of a withdrawal coping mechanism. and they also feel that fatigue that comes with depressed mood. There may be a significant anxiety component. Panic attacks can happen postpartum for the very first time. Feelings of worthlessness or inadequacy as a mother, negative thoughts such as my family would be better off without me, or I made a mistake, or my baby is so beautiful, why am I not a better mother? So there's all those feelings of inadequacy and worthlessness. Thoughts of hurting self are not usually your primary symptom, but they can develop, and this is when things get dangerous. And there may also be an OCD component, and you get these intrusive thoughts, like something, the baby's choking, baby's not breathing, and they have to check the baby, or baby's not getting enough milk. I mean, we all worry about the baby getting enough milk in the beginning when we're breastfeeding, but you know, taking the baby to the doctor, always thinking something bad is going to happen, the baby's going to fall off. They may have visions of the baby falling off the changing table. So there could be an OCD component to this. What we do about it. So it's a combination usually. It's therapy and medication. It does have a biological basis. And so a lot of times psychiatric providers don't like to prescribe to breastfeeding mothers. So they'll tell mom, you have to stop breastfeeding or I won't give you this medication. And that's sort of unnecessarily cruel. Most medications, most of the SSRIs at least, MAOIs are a different ballgame, but most of the SSRIs are compatible with breastfeeding, especially like Zoloft or sertraline is its generic name. They have given Prozac, but Prozac has a longer half-life. Zoloft is a little bit shorter. But the SSRIs are usually considered safe with breastfeeding, and they're better. The breast milk and the exposure to SSRI, like the benefits outweigh the risks most times. And that the antidepressant can really help mom gain from therapy. Some women with milder depression might be able to just do cognitive behavioral therapy, which would be an individual therapy that addresses those negative perceptions and distortions of thought, sort of like I'm worthless as a mother. You would take that negative thought and you would replace it with a more realistic thought, like this didn't go the way I planned it, but I love my baby. Support groups are wonderful for women with postpartum depression. The issue can sometimes be finding them in an area where you live at a time where you have someone to care for your baby. And getting there can sometimes, if women aren't driving. After a C-section, we don't let women drive for a significant period of time. It's usually about 8 weeks. So support groups can be good. There are several online support groups that are really wonderful, like Postpartum Support International has one, and these can be referrals that you give to parents. Sometimes you can give them the discharge folder. A lot of times pre-printed materials will have that information in case the woman needs them. But it works best if they have that support from the antidepressant. There's a newer agent now called brexanolone or Zupresso. It's very pricey. It's an IV treatment. They have to go in and be treated with it. And I think it's like a one-time dose, but it addresses the hormonal component and doesn't have the side effects of an SSRI. And this has been really helpful and kind of game-changing in the treatment of postpartum depression. So keep your eyes peeled for more information on that. ECT can be used in severe cases. I did talk to an ECT nurse once who thinks that they should probably use it before it gets to that severity level because there are fewer side effects to it. But at this point in time, ECT is only recommended for cases that are severe, that don't respond to the SSRIs. And the big thing with ECT is that it works after like 1 or 2 treatments. Within a week, that woman should be feeling a little bit more like herself, whereas SSRIs can take up to 4 weeks to take full effect. And then there are some alternative treatments for milder forms of postpartum depression. Exercise, physical exercise like walking, has been helpful in the treatment of postpartum depression. Exposure to light or light boxes or sunshine has been helpful for some women. You might want to caution your mom away from any herbal supplements without the consent of her provider. Preventing suicide is going to be one of your biggest priorities, just like we learned in psych. Um, the thing is, most people who are that miserable with major depressive disorder who are not new moms will start to seek help, hopefully, before they get to the point where they think that their families are better off if they're dead. But women will suffer in silence because of the stigma. Some women, especially women of lower socioeconomic status, may stay silent because they fear child protective service involvement. And sometimes that's almost a legitimate fear when you see some of the cases with child protective services. Oh, sorry, I got to go back in time again. That was But let's go back to preventing suicide. There's only two more slides. So, like all patients with depression, the highest risk is when we start treating them. When they are in the midst of untreated depression, they have the desire maybe to die or the desire not to live anymore, but they don't have the energy to carry out a plan. As their energy starts to increase with treatment, they have more of an ability to carry out that plan. They have more energy, they can do it. So we always want to assess suicide risk in a patient who comes forward in a non-judgmental way, make her know that it's okay to tell us. A patient who's at extreme risk, a patient who has a plan and a date and a time and means and access to those means, is a patient who needs to be hospitalized and stabilized. Safety is most important. And this is where, a lot of women are reluctant as well. They don't want to go into a psychiatric facility. There's a stigma to that as well. And these are typically, when you see this, sometimes there's a history, but it can strike out of the blue. They can have none of those risk factors and still suffer postpartum depression. And so there's a stigma to being hospitalized, and they don't want to be separated from their babies. But, if you kind of emphasize to people that, look, a short-term separation is better for you and better for your baby. Babies actually meet their milestones later if moms are depressed. So if we treat you for this, we keep you safe, we give your baby a mother, and you're more present for your baby, and he or she will develop more appropriately. So then we're going to go on to postpartum psychosis, and it's rare. It's about 1 to 2 women. Your book cites this statistic in 1,000 births. But if you have a woman with a history of bipolar disorder, watch out, because the incidence is 100 times higher than that. And when you get into postpartum psychosis, the risk for suicide and infanticide is extremely high, relative to the risk with postpartum depression or any other disorder. And this is because the delusions sometimes make them feel that the devil is possessing their baby, or that their baby has a horrible disorder, or maybe, there are all types of delusional thinking that can occur with postpartum psychosis. This is where we see cases that get on the news. The woman who straps her baby into a car seat and drives into a lake. Andrea Yates drowned all 5 of her children in the bathtub. Because they're psychotic. They're not thinking rationally, and the delusions tend to center around some condition of danger with their baby, whether their baby has been possessed by the devil, or their baby is an alien or a changeling, all these bizarre types of unusual thinking. They may also hallucinate. Auditory hallucinations are very, very common. They're hearing voices. There's a feeling of depersonalization, where things are happening and they're not really there. They're sort of outside themselves. On the outside, what it will look like is bizarre and disorganized behavior. One case of postpartum psychosis that I remember seeing in a psych hospital was a woman whose sister found her naked, flapping her arms like they were wings around her apartment. The baby was totally neglected, sitting in the car seat, hadn't been changed in so long that the diaper was practically sticking to them, horrible rash. So you see that neglect of self, a lot of neglect of hygiene, just like you see with any psychotic patient, and neglect of the infant. In this case, it's responsive to treatment most of the time. Remember that these disorders, there may be an emotional or psychological basis, but there's a lot of biology involved in it too. And if we're dealing with something that started with a hormonal shift, and maybe this woman already had some neurotransmitters that were a little bit unbalanced, she will respond to treatment. The recommendation at this point is for the lowest dose of one agent. This isn't where you want to hit them with like 3 different drugs. So antipsychotics, hospitalization, you need to keep the baby safe and you need to keep the woman safe. Suicide and infanticide are very real risks in this disorder. You need to stabilize mom on antipsychotics. And this is where you really need buy-in from the family, because sometimes spouses don't want to believe this is happening. This is the woman they love. And they aren't used to seeing her like this. They go into a deep denial. They want to believe that their family is going to be okay. And so sometimes you have to talk to them about how serious this is. Another factor is that if the woman is breastfeeding, most of these agents are not compatible with breastfeeding. Lithium in particular causes a lot of problems. If it's a bipolar incident, more of a mood disorder with that. But a lot of the antipsychotics really are not compatible with breastfeeding. And at this point, I mean, think about the psych hospitals. We were at Episcopal and some of you were at Einstein. Most of them really aren't equipped for breast pumping, and the hygiene may be a factor. So we don't want to, lead to mastitis. On the other hand, if she was breastfeeding and has a supply, we might want to wean gradually. And that would be an occasion where we would get a lactation consultant to come in and help her express milk. And support groups for the woman who's suffering from this, especially as she recovers and comes to terms with this experience that happened, which can be very traumatic, but also support groups for her family dealing with this. It is very difficult for somebody to lose someone they love to a postpartum psychosis episode. Even if they make a full recovery and never have another psychotic break, it's very hard for family to deal with that. And that is the end. Thank you very much. I will see you in class.